Thank you so much. And I think all of you can see there in the credentials behind my name that I managed to get through the residency program, and now I'm now a boarded specialist in the American College of Animal Welfare. So where it says DACAW, I used to say DACAW resident, and I actually got my boarded specialty credentials there in June of this year. So I'm really excited about that. This talk is jam-packed. We are going to cover a lot of information related to, providing the pharmaceuticals that we need for euthanasia and trying to do it as comfortably as we can. So I'm going to try to move through probably 2 hours of content in 1 hour and provide enough time for some questions and answers. But when you look at this title, you probably already have a question in your mind of, well, is euthanasia inherently painful? Do we need to put this much effort into trying to reduce away that pain and keep our patients more comfortable? When we think about just giving pentobarbital into a vein, when pentobarbital enters into the blood system and works its way up to the brain to achieve death, that in and of itself is not painful. It's what might go along with it in prep to give that pentobarbital. That's what we're going to focus in on today. So it's a bit more of just the actual injection itself. It's more complex than that. So yes, euthanasia without pain can be done. And those of you who are attending this webinar are probably here because you've seen painful euthanasias. And my heart does go out to you because they are so difficult. They can really haunt us, leave us feeling upset and wishing that we could go back in time to make changes and reduce away that pain. So when we know better, we do better, and that's our legacy. And that's why you're here tonight, is to learn how to improve these techniques as best we can. Our agenda, we're going to talk about what caregivers or clients, pet owners, pet parents, whatever term you want to use, what they consider painful or difficult or, unpleasant to see. And we might refer to a difficult euthanasia as a dysthanasia. That might be a term you've never heard of before. We will review some pre-euthanasia sedation and anesthesia protocols and the ways that we can reduce down pain when we're giving those. We're going to touch on euthanasia techniques themselves and talk about the importance of minimizing pain during things like intra-organ injections or IV injections. And you are going to see some actual euthanasia videos today with this webinar. So if that is in any way upsetting to you, just know that once we get to those euthanasia techniques section, you may certainly turn away and not view if you wish. But I just want you to know that ahead of time. And then what to do if pain does happen, right? How do we address it with our client? And again, try to create that legacy and something good that can come from it, which ideally is helping further patients not to experience the same painful episode. Now, while Zomedica does not have euthanasia-specific products and offerings, what I like about Zomedica and why I agreed to do this webinar is because they do have a couple of products that are focused in on reducing pain and stimulate and promote healing with our patients, things like PulseVet and Assisi. In particular, I've been using the Assisi products for years with my hospice service, still use it for my own patients and my own pets. And absolutely love that product. So I just want to say a big thank you to Zomedica for putting time and energy and attention to these really great products like PulseVet and Assisi. A little bit more about my background. I have been practicing advanced end-of-life care since 2006. I ran a mobile euthanasia and hospice service in Colorado. That's where I'm coming to you from today. In fact, I'm sitting in this little blue building that you see here. And I love doing mobile work for a long time. Really helped me to hone my euthanasia skills and make it the absolute best I could for my patients and for my clients. And I was exclusively by myself when I was out during these appointments. So when you're thinking about how best to deliver pre-euthanasia sedatives and anesthetics and the technique itself, I want you to picture doing it by yourself, solo, or maybe you've got an assistant, whether or not that's your technician. Maybe you're the technician watching this yourself, but it can certainly be a team effort. I just happened to be solo those years. The practice itself, though, did have 9 doctors and 5 support staff. We just traveled around independently, like you see here in that bottom left picture. After a few years, I did start a euthanasia comfort center here on my farm. That is the little blue building that you see there. And I still perform euthanasias today, and also do some euthanasia work at the local animal shelter. I've been volunteering there for quite some time, helping out their staff. I did run an aquamation service called Guardian Pet Aquamation for about 9 years. Aquamation is water-based cremation, and that was wonderful, wonderful company to run. Really enjoyed it. And as it says, I am author, speaker, and researcher for the Companion Animal Euthanasia Training Academy. So even right now, I'm doing research on improving euthanasia techniques, finding alternative techniques so that we can continue to make it a smooth procedure in a variety of settings and situations, and of course, reduce pain as much as we can. I'd like to introduce you to the 14 essential components of good euthanasia. This is meant to be your blueprint to think about before the appointment and then during and after. Are you providing these things each and every time? And you'll see that one of the letter A's in euthanasia is avoid pain and anxiety. It is an essential component. And how we do that is through the use of pre-euthanasia sedation or anesthesia, by delivering proper technique, creating safe space to gather. Even inclusion of loved ones can help to avoid pain. So all of these are rolled into a good euthanasia appointment, but today we're going to focus in on that letter A, avoiding pain and anxiety, through those other things that I mentioned. Hopefully you've seen this article before, but this came out a couple of years ago, where myself and Dr. Lori Kogan at Colorado State University looked at how pet owners define a good death. Why we did this particular study, and you can read about it in DBM 360, was because we had started to develop this concept a bit deeper about a dysthanasia. What's a bad death look like? Well, it's difficult to define a bad death until you define a good death. And a good death in modern times, where we've got the companion rolled into that definition, as well as the pet patient themselves. And this is what we came up with after surveying those 2,000 some pet owners, as well as another survey that we did with veterinarians to ask how they define a good death. So I just wanted to share it here with you, because you're going to see that it includes minimal to no pain or anxiety. So if we start with the beginning, it's the proper use of technique to end the life of an animal, very textbook for euthanasia, with minimal to no pain or anxiety. Again, very classic for AVMA euthanasia guidelines and some other guidelines that are out there. That's what we're aiming for. That is what starts us out with a good death. But now it is best facilitated through the use of sedatives and anesthetics. And what CADA teaches is that we're giving these sedatives and anesthetics before the placement of an indwelling IV catheter. You at your practice might be placing catheters and then administering propofol, which is indeed an anesthetic, followed up by pentobarbital. What we're suggesting is that you're actually going to be giving these sedatives and anesthetics ahead of any real technical aspect of the euthanasia procedure itself, especially something that's going to require a lot of restraint. That allows the informed pet owner to remain present for the entirety of the procedure. Since pet owners define this now as an integral part of a good euthanasia experience, this means that they're witnessing, watching, and are present for everything that we are doing with their pet. That means that we have to avoid pain from the very beginning all the way through. And that holds us to a higher standard, and I like that. Yes, it adds more pressure, but the standards and the outcome are much better. So let's talk a little bit more about pre-euthanasia sedation and anesthesia. Those of you are likely using it already have found it to be a huge blessing and an improvement to your euthanasia work, that your patient is truly sleeping in those final moments. And these are some of the other benefits that it brings, closeness with the pet that might have been too painful for such a thing, haven't been able to be snuggled in a long time and have resisted that connection. Also provides an opportunity for one staffer or one person to perform the whole procedure, because less restraint is required. And then this last one is important, that it is actually a euphemism for death itself that can help the loved ones prepare for that moment when their pet actually stops breathing and when death has come. So you provide pre-euthanasia sedation or anesthesia, and they are different, so that the pet is comfortable and sleeping, and it looks like they've passed, but of course they're still breathing. So when you give that euthanasia solution, all that really changes is that the breathing stops. Okay, so it can help the pet owner and the client start to prepare, because now their pet is no longer aware that anything's even going on around them. So sedation and anesthesia are different. Sedation is generally a lighter state of sleep, whereas anesthesia, we're reaching for true unconsciousness. Think stage 3 anesthesia, surgical depth, so that anything that you are doing to your patient, they cannot feel it or perceive it. These are my protocols. I'm going to show you a slide for dogs, and I'm going to show you a slide for cats. I'm not going to dwell too much on this, so you're welcome to take a screenshot if you wish. But my protocols for dogs are different. I have a sedation protocol and I have an anesthesia protocol. And why that's important is because if I'm using a sedation protocol where dexmedetomidine is really taking the lead, inducing that deep state of sleep, it's still not enough for unconsciousness. So if I'm planning on doing an intra-organ injection, like an intracardiac or an intrahepatic or an intrarenal, I need my dogs anesthetized. So therefore, I'm going to use my anesthesia protocol that has teletamine. Teletamine's an anesthetic. If I do it at a proper depth, at least 2 mg per kg. I prefer to go higher, but at least 2 mg per kg, along with some added benefits of acepromazine or dexmedetomidine, then I'm going to get a nice, deep, comfortable unconsciousness and anesthetic depth. And that's what we're aiming for. So for dogs, I have 2 different protocols. So if I'm going to just place an IV catheter and just have venous access, I feel very, very comfortable going with heavy sedation versus full-on anesthesia. You might want more choices, and therefore you're going to go with anesthesia every time. These are my feline protocols. Again, you're welcome to take a screenshot. The anesthesia protocol on the top is probably my most common. I use the teletamine, ACE, and butorphanol regularly with my cat patients. And on the bottom, though, you see an alfaxalone one. So alfaxalone's the anesthetic in that one. And why alfaxalone is nice is because it is more of a neutral pH. Teletamine's got a low pH, meaning it's got some heat to it. It can sting. We have to be careful of that. Alfaxalone is much more benign. So if you want to start using alfaxalone more regularly for your feline patients, I would encourage that. And it works on a total different anesthetic pathway, and you're going to see very different reactions from it, but hopefully less pain. There are a few different routes of administration. We've got subcutaneous, intramuscular, intravenous, inhalation of gases, and then oral administration of some of these drugs. It's all about choosing the one that is best for your patient, given the circumstances, to try to avoid that pain. My tips for these, when you're giving an injection in particular, whether or not it's sub-Q or IM, is to move slow, move calmly, and create a sense of ease around your patient, right? Get them used to your touch if they're comfortable with that. And distract if you can. I'm going to give you some tips for that in a moment, but distract as much as you can so that they're not as focused on what you're about to do, which is to poke a needle underneath their skin. So prepare the pet by rubbing the area as much as you can. Again, desensitization is really helpful. Tent the skin often if you're going to be going in specifically for a sub-Q injection, but then inject slowly unless you have to go fast. If you have a really wiggly body, super active, like you've got 3 seconds to get this in before they move, then I can see you injecting a bit faster. My preferred needle size is usually around a 25 gauge needle. You can go smaller than that at a 27. At the shelter, I actually tend to go a little bit bigger with a 22, not that unusual. They tend to be larger dogs, more of aggression cases, and the dogs don't seem to notice, and it helps me get it in rather effectively. So those are just some of my tips there. I'm going to go ahead and play a video for you of an intramuscular injection of this feline patient. She is very, very thin, paper thin skin. So I actually chose to go with a thigh injection for her versus the epaxials. I like the epaxials as my injection location because we do have science that tells us that they're least likely to notice it, but she's all vertebrae. She's also covered in mats, which makes it difficult to locate nice, easy spots under her skin. So that was me injecting the teletamine protocol with some acepromazine and butorphanol in it. And you can see she barely responded at all. Now, if I were more concerned that she would respond, I would have more hands on her or have a helper with me to do that, but she was doing just fine. This is a subcutaneous injection. You guys know how to do this. I'm just showing you what I do. I don't know if you can see that little photo bomber in the window, but there's a little pug sitting there going, "What are you doing to my sister?" So this is just how I would do a subcutaneous injection. You can do it in the epaxial area. You can do it over the thigh, wherever you've got loose skin, again, where you can distract as much as possible. So speaking of distractions, food for those who are eating is wonderful. So I'm going to go ahead and play this little video of this cat eating this churu. I think it's fabulous how focused this cat is on this little tube. I use churu now for my cats and for my dogs because it's like manna from heaven for dogs to get some sort of cat food. And I rarely have patients turn it away. So it's just nice to carry those. I'll tell you, I actually use the lid of my churu tub as a little bowl. So I've got a little orange bowl that I squirt my churu into, in particular for my canine patients. So just something to think about if you've got that little tub. So churu, cream cheese, pill pockets, bacon, you name it. Anything that's a high reward food for that particular pet is great. The picture of the dog at the bottom there with the banana is just to remind us that sometimes favorite foods aren't what we think of. I had a patient come in, not this particular dog, but another one, that dog just loved bananas. In fact, we had a banana scent in the room. We had a banana bed. We had a banana bandana. Everything was just banana to send this dog off during the euthanasia appointment. So ask your clients, get curious, what can we have available or what can you bring in to have as a good distraction food? My pug, by the way, that I have is a big fan of oranges. She'll do anything for an orange slice. Now, if we can avoid giving an injection underneath the skin, at least to start, if we can get some other drugs on board to relax our patients, we should do that. So these are known as oral pre-visit pharmaceuticals. And Kata wrote a blog, geez, that's already 3.5 years ago or thereabouts, that we wrote this blog on oral pre-visit pharmaceuticals. Go big, right? Get as much drug in there as you can orally and relax your patient down. So by the time they arrive to the hospital or you arrive to the home, if it's for home euthanasia, you've already got a patient that's less likely to notice those injections. Definitely good for aggression cases and for high anxiety too. This is my modified chill protocol for dogs. The chill protocol you might be familiar with. It came out of Tufts University with Dr. Alicia Karras and her team, where they came up with gabapentin and melatonin the night before, and then gabapentin and melatonin plus acepromazine the day of a particular time before the actual euthanasia appointment or anything, right? The chill protocol is designed for just to reduce anxiety for any sort of visit, but I have bumped it up considerably for euthanasia. So these doses are much higher than the traditional one. What I've also done for canines is I've layered in ditomidine gel. This is the Dermosidan gel from Zoetis. It's ditomidine, which is an alpha-2 gel that just goes transmucosal to absorb in. And in my experience, at a dose like this, my patients that are highly aggressive in particular, that are arriving at my comfort center, are really deep sleep. That said, they're not unconscious because gabapentin, melatonin, ACE, and ditomidine are not anesthetics. So if I'm ready to move them in the back of the vehicle, I actually might give them a poke, and typically do, of teletamine ahead of time to really get them deep into unconsciousness before I start moving and manipulating them. The dog that you see here in the picture is a dog that was very aggressive with me the day before when I got these drugs together for it. And then the family gave it that night of, and then the day before the appointment and a little bit right before the car ride. So she came to me sound asleep, snoring. And that's exactly what we want for canine aggression cases or any animal who's going to be highly sensitive or very painful. This is Lulu, one of my patients. Oh, and by the way, look there in that left picture. There's that little tub of churu, and you can see that orange lid. That's what I use as my bowl for dogs. So Lulu came in, and while she wasn't necessarily painful, she was very high anxiety. So just giving her some of that ditomidine gel really took the edge off. There you can see in the right picture, she's already starting to relax, and I'm still talking through things with the owner about, how things are going to take place and what this is all going to look like. But Lulu's already got some nice relaxing drugs on board. So that's wonderful for her. So when it comes time for me to inject her, if she does notice it, she's less likely to have a negative reaction. But Lulu didn't notice a thing. So factors that may worsen an injection reaction could be, first of all, just patient temperament, kind of like we just talked about with Lulu. Their acceptance of handling in general. I worked with a cat yesterday that was doing great, cruising around my comfort room and relatively comfortable with that. But as soon as we started to hold her, she got irritated. So we knew that she was more likely to respond. So I started with what we call more benign protocol with butorphanol and acepromazine because she's less likely to notice that heat from thalidomide that I gave later on. Okay, so what is their general acceptance of handling? How about their experience with injections, right? Have they had a lot of injections? Are they familiar with that tenting and scruffing? And how have they done with it in the past? Can we avoid injecting a sore area? Because if we're injecting a sore area, they're more likely to respond to that. Do they have hypersensitivity to things such as through allodynia or hyperesthesia? And are we rubbing an injection area immediately post-injection that could cause pain? You think about thalidomide and ketamine and midazolam, those are our low pH culprits typically. So if you're giving an injection of those and then immediately start rubbing, due to the damaged tissue that's there from the needle, we can actually cause more pain. So I like to wait just a second before I start moving my fingers around and massaging that area. And by the way, I massage all the time. So once I've given these drugs, either intramuscular or subcutaneous, I like to massage, and help to work that in, which speeds absorption and shortens time to sleep. So preparing the client ahead of time before an injection is important. I would encourage you to ask, how has he or she been with injections in the past? And are they sensitive somewhere that we should know about so we can avoid that? And you may find that your patient's going to notice and be painful no matter what you do. So if you can actually give oral medications, especially like that ditomidine gel for the dog, do that. Right. And now you've got some onus together with the client who you've made the decision. Yeah, we're actually going to start and do something orally versus giving something an injectable that could cause pain. But if it turns out that the patient hates their mouth being messed with, that they have a lot of oral ulcerations and missing teeth and abscesses, that can be painful if you're putting a lot of drug in there. So maybe it is better to give an injection. Therefore, if your patient reacts, hopefully it's temporary and they're going to forget about it quickly. You may describe anything that does have a lot of heat to it or a little heat to it as such, right? So I might say, it's possible that she might notice this, but I'm going to be as gentle as I can. And we're going to just go with whatever she needs. If she reacts, I'll go ahead and stop and we'll figure out another course of action. If he or she talks to me, I understand injections are never that much fun and they're going to forget about it very, very quickly. Sometimes getting these medicines in sooner than later is better for our patient than dragging things out, especially if they are very uncomfortable in their body. Let's just get these drugs on board and so they can welcome that pain relief as quickly as possible. These are the drugs that we're talking about using much of the time. Now, you already saw my protocols, but here are some of the other drugs that are out there that we typically lean on for euthanasia. And in red are the low pH ones. So if we're talking about something that's got a little heat to it, it's that. And yes, you're thinking to yourself, Dr. Cooney, propofol also can hurt and sting if it gets outside of the vein. But if we place our catheters right, then we don't have to worry about that. And we're never giving propofol specifically, purposefully outside of the vein. There's been conversation out there for quite some time about how to remove the dissociative sting. Dissociatives are ketamine and taletamine. And so there's been discussion about what can we do to add something to these syringes and neutralize that pH or just take away that burn. So I put together some diluents, if you will, and additives that I've been working with and their pH, and then what they actually look like in telazol. I haven't tested it in TZ and some of the other taletamine products. I've just tested it in telazol. So if you mix in saline with telazol, it's going to be less than 3 is your pH. Just a reminder that neutral is 7. You mix in plasmolite, you're going to get around 3 to 4. Buffered lidocaine, which you actually have to compound. You can't just buy buffered lidocaine. You have to compound it. And it still, in my experience, came out quite low. So even though I tried to produce buffered lidocaine that had a pH of 7, I got to around 5 most commonly, and when I mixed it with telazol, it was still pretty low. B12 is a big one out there we've been talking about that I don't know why it works. If it truly does, maybe it's the dilution is solution to pollution, pollution being the low pH of a dissociative. But when I tested it with telazol, it was still a low pH, so not sure why that one works. The other two down below show pH buffering solution, and acepromazine kept the pH quite low. But look at that bicarb. If you are interested in dropping a little bit of bicarb into your syringe before you inject, right now, that is the solution I have to get you to a neutral pH and reduce that sting. You can find a good bicarb protocol in this blog that we wrote last year on reducing pain during pre-euthanasia sedative injections. You are also going to find in that blog a couple of other protocols by colleagues out there that swear by them and reduce away that pain. So it's too much for us to go through all of those protocols tonight. So we've got that blog for you, and you can find it at cadainternational.com. So I really like this idea of adding just a couple drops of sodium bicarbonate to get that to a more neutral pH right before you inject. Yep, you can see a little bit of fizzing and things like that, but read that protocol and that will help you know what to do. In that blog, it also talks about this idea of a 1-step versus a 2-step protocol for these drugs. If you are worried that your patient is going to react to taletamine or ketamine, perhaps you don't start with that, right? Rather than having the drugs combined into one syringe and just giving them, maybe you tease out the butorphanol and ACE first and just give that maybe sub-Q. Allow your patient to relax with it, to get more comfortable, start to let the world around them go, utilize the analgesic there in butorphanol. And then when they're more comfortable, you follow it up with an IM injection, typically of ketamine or taletamine, or both. You can have them in the same syringe, mixed in usually with a little more ACE or more butorphanol. Maybe it's a little bit of dexmedetomidine. But now you're just giving the second injection that's going to truly anesthetize them. Now, this isn't necessary if you're just going to place an IV catheter and they've relaxed enough with butorphanol and acepromazine. That's okay. If they're really comfortable and pretty zen and chilled out, and you feel like you could place an IV catheter safely and then follow it up with euthanasia solution, by all means, you may do that. But if you are planning on doing an intra-organ injection, like it's become much more common in cats, then you need them anesthetized and you need to give that ketamine or taletamine. A reminder as well that if you still want to use propofol, could be a part of that second step. So rather than giving or placing an indwelling IV catheter in an awake animal, and then giving propofol followed by pentobarbital. How about we give them some butorphanol and ACE ahead of time, relax them a bit, wait 5 minutes, and then go ahead and place the catheter. And then you can give your propofol or just go right with your euthanasia solution if you feel like that's best. Let's move on now and talk about choosing the right euthanasia technique. And this is my nemesis, by the way, is the Pekingese, or was my nemesis for a long time until I discovered intrahepatic injections. And then I didn't sweat at all when I had a Pekingese on the lineup for the day for euthanasia. But when you look at this dog, you think, what's the challenge? The answer is dog, right? Brachycephalic, lots of fur to contend with, short little legs, often has heart disease, you know, you name it. So it can be a challenging one. So choosing the right euthanasia technique is important. And the most common ones for us with pentobarbital are these. It's going to be intravenous injections, intracardiac, so that's into the heart, intrahepatic into the liver, intrarenal to the kidney, or intraperitoneal into the abdomen. I don't talk a lot about intraperitoneal. I think in this talk, I might find another slide coming up here, but right now I'll just mention that there's kind of mixed reports out there of whether or not giving intraperitoneal injections of pentobarbital in awake animals is painful or not. In my experience, I have seen it be painful, and I've also seen it be very comfortable. It's a matter of properly placing that needle just through the abdominal wall and infusing in that euthanasia solution into the abdomen. My guess is it's going to be more painful, and I've certainly seen it, when we believe that the needle's been accidentally positioned into an organ, or maybe a loop of bowel, or maybe it didn't even penetrate through the body wall and it's accidentally going intramuscular or something like that. So there's a couple different ways to view that, and there is different reports and in scientific journals about it, but I have seen it both ways, be comfortable and uncomfortable. These are your doses. And just for clarity's sake, because I'm not sure where you're tuning into this, whether or not you're in Canada or another country, that the dose that we have for intravenous and intracardiac is 85 mg per kg. That's what we say here in the United States. That's a minimum. Intrahepatic is 170 mg per kg. And intrarenal and intraperitoneal are 255 mg per kg. So it equates to what you see here based on 390 mg per mil of pentobarbital euthanasia solution. You might be asking yourself whether or not you can use the pink euthanasia solution and have it be the same dose. Yes, you can. Here in the US, we have the pink and the blue euthanasia solution. They are the exact same concentration, 390 mg per mil. My recommendation for you, though, is that if you're going to be doing intraperitoneal regularly in awake animals for that euthanasia solution to just infuse into the body and get itself up to the brain to do its work, you really should be just using the blue euthanasia solution for that, because it's pure pentobarbital and is safer. Circled here for you, intracardiac, intrahepatic, intrarenal. These are the techniques that require pre-euthanasia anesthesia, unconsciousness, before you attempt these. So if you're trying to do euthanasia without pain, that's what's required. It is actually could be considered malpractice if you are using pentobarbital awake with these techniques, because it's likely that your patient will react. We have, with CADA, we have a euthanasia review department where pet owners can reach out to us and talk to us about what they consider a dysphagia experience. And still to this day, one of the most common complaints that comes in is intracardiac injections on awake animals. Now, if you're very seasoned with euthanasia, you know that's something we don't do, but it does still happen out there. And yes, animals are very painful because of it. So protect yourself, protect your patient, protect your client, and follow the AVMA's euthanasia guidelines and have your patients pre-anesthetized before you attempt an intracardiac injection. Here are just some quick tips for you to improve intravenous injections in your patients. You are welcome to take a screenshot of this as well. But indwelling catheters are ideal for awake patients. That's going to cut down on your risk of extravasation because pentobarbital, if it gets outside of the vein into the subcu space or into the muscle, very, very painful, especially in our mammals. Use the longest, most visible vein. The back legs are preferred. And clip the fur to improve success. You're going to inject your pentobarbital very fast if your patient is awake. If they are heavily sedated or anesthetized, you're actually going to inject slowly. That has nothing to do with cutting down on pain. The purpose for that is to cut down on active side effects or active signs of dying, such as agonal breathing, opisthotonous stretches, things like that. So if your patient is awake, you're going to blast that euthanasia solution into your indwelling catheter as quickly as you can. And then if they're heavily sedated or anesthetized, you can go much slower. My rate is 0.1 mil per second. Now, while we look at intracardiac injections, I'm going to go ahead and play a video in the upper left. This is a tip for how to use a little extension set so you don't have that big gush of blood like what it looks like in that upper right. So really nice to use that little extension set to hide the blood from your clients. Very, very effective. Another nice way to do an intracardiac injection is what you see in the bottom right. This is actually from the ventral side. And therefore, you don't have to come up over the top with that flash of blood. You might be able to kind of shield that a little more. The picture in the bottom left is essentially what the client would see, similar to what we just did in that video up above it. So with that little extension set, I have that in my hand there, and you can't see what's going on. So to the client, they don't see that big flash of blood. It looks rather pleasant and benign. This is what we teach with the CADA program over and over and over again, is the better ways to do euthanasia techniques to set you up for success so that you have a plan A, a plan B, and a plan C ready to go. These are intrahepatic injections, and I do have a little video going on the bottom there. So you're going to see an intrahepatic injection done in a moment. Reminder that these patients require unconsciousness. They must be unconscious. And while I don't do this in the video, it's worth pointing out that you should actually start injecting very slowly. This is an older video before I learned that tip. And what's beneficial about injecting slowly first with an intracardiac, intrahepatic, and intrarenal is that you may assume that your patient is anesthetized, but what if they're not? What if they're not as deep in sleep as you think they are, and you all of a sudden blast in a bunch of pentobarbital into an organ and stretch out the tissue or the renal capsule as an example? It's likely that your patient's going to react in pain. So test it out a little bit. Give a little 0.1, little 0.2, little 0.3. Make sure they're not reacting, and then you can start to infuse in that euthanasia solution a bit faster. Now, with the intrahepatic injection, I don't know if you saw me move my needle a little bit, but I tend to insert that needle in. Dog this size, 1.5 inches is good. Insert in that needle, and then about halfway through the injection, I like to redirect and kind of bathe that liver in euthanasia solution. My patient's unconscious, they're not going to feel anything. I say in here better for smaller pets because for me, my comfort level is about 40 pounds and under. But if you're needing to use this in larger animals, by all means, just have a lot of solution ready. And it's possible that if you miss the liver, you've actually done an intraperitoneal injection, and it could take a long time. So that's why I say maybe it's better in smaller pets. Intrarenal injection. Here you see the little kitty that we anesthetized earlier with that teledamine protocol. She's completely out and sleeping, unconscious, and I'm using my left hand to locate that left kidney. Takes me a second because she's covered in mats, but I insert in that needle. She doesn't feel a thing. It's an 18 gauge 1-inch needle I just inserted into her kidney. And you're going to see she's going to take a deep breath. And then she's going to exhale, and I'm not even done with my injection yet. So it's a very smooth, elegant technique for any patient that is anesthetized where you can feel their kidney. So as it says here, disease is not a factor. Remember to start slow and then speed things up. And you're trying to feel for kidney swelling. That's what we're looking for. So what to do if pain does happen, whether or not it's with a pre-euthanasia, sedative injection or anesthetic injection, or for the technique itself, you're going to need to address it, especially if your client has expressed concern. So feel free to say, oh, sweetheart, I know you felt that, but you're going to forget all about it very, very quickly. And I promise you, you're going to feel so much better. Compliment the pet. Aren't you wonderful? You are such a sweetheart, and we're here to take care of you. Just things like that to make sure the client understands that you have your patient's best interest at heart. But apologize if it is warranted. Okay? If you're not quite sure how the family has felt about things, maybe reach out in the next 24 hours. Just let the family know you're going to be calling. Have somebody who's very informed about what happened call so that they can address any concerns that the client had. And make sure to provide ample time to talk about it. When pet owners reach out to CADA to share a dyskinesia experience, 99 times out of 100, it's due to the fact that they didn't feel like their vet team communicated enough with them about what happened during the moment or afterwards when they wanted to just understand why did their pet react in such a way. And what they want is for you to create a positive from it so that you can prevent it from happening to other patients, right? So if it happened to this animal, hopefully it won't happen to another. That's just creating a legacy of goodwill and kind of paying it forward. And then ideally debrief with your team about it so you can all figure out whether or not this is a normal occurrence, right? We've got a lot of cats that are reacting negatively to something, or maybe dogs are responding to those intrahepatic injections and they shouldn't be. So now you can talk about updating your standard operating procedures and avoiding those in the future. Would also encourage you to have in your medical records kind of a rank to your euthanasia appointments, such as green is perfect, right? So textbook euthanasia, no concerns, patient very comfortable, client content, grateful, and the veterinary team was happy. Those are greens. A yellow rank would be maybe the client expressed some concerns or the patient reacted in a way that you didn't like, and you were a little concerned about it. Maybe that's a yellow. Probably your client's still going to be happy with things, they're going to be forgiving, but you're a little more concerned about it. And then you've got the red. The red is where the client was very upset because the patient had a bad experience. You're upset about it. You're haunted. And now we've got a true dyskinesia on our hands. So when we're talking about debriefing with the team, it's helpful to be able to identify those appointments that have gone a little bit awry. And then you can, again, talk about it and adjust your protocols accordingly. And if you're really concerned about a dyskinesia, maybe it's an opportunity to call in reinforcements or call in somebody else who can handle this patient perhaps better than you. You're going to be amazing at what you do, but every once in a while, you're likely going to come up with what you would consider a challenging appointment. And could there be somebody else that can handle it in a different way? Especially if it's going to be home euthanasia, right? Is there an opportunity to keep the patient at home where they're going to be more comfortable? And maybe that home euthanasia provider does this a ton and they've got some other protocol. Maybe they've got other drugs that you don't have that could be a better fit for this patient. So just think about it ahead of time. If it's especially not a euthanasia emergency where you've got more time for pre-planning, perhaps it's an option. So I'm going to share with you summaries, and then I'll lead us to our closing slide, and then we can get to our Q&A for a good 10, 15 minutes or so. For summary, avoid pain right from the start. So be thorough. Think about it. What's going to be my best approach for this cat versus that cat, for this dog, for this rabbit, for this horse, whatever patient it is that you are working with? Be very thoughtful. I want to avoid pain from beginning to end. What am I going to do? Okay. So hopefully you can use a lot of these tips. If you're using low pH drugs, just know that they are going to hurt a little bit more. So maybe you're going to lean on those additives. That kind of dilution is the solution to pollution, and cut down on that heat and that sting. But if you can avoid them altogether, maybe for cats you're using alfaxalone, or for other small mammals you're using an alfaxalone protocol, great. Or you're using a two-step where you're putting in that butorphanol and ACE first, allowing them to relax, and then you're giving something with more heat. Inject slowly with those intra-organ injections to make sure that your patient won't react. Also, keep in mind, how do you test your patient to make sure that they're ready for you to do anything? You're going to do those deep toe pinches. Okay, so grow your little pinchers like I do, your little fingernails, and pinch in between those toes. And if you're going to be doing an abdominal injection, you should kind of massage the belly a little bit and make sure there's no tensing of those muscles. You can do a corneal check like a reflex, but more than likely they're still going to blink even under anesthesia. So that's not your end all be all. It's really that they're not responsive to deep pain, and they're completely limp, right? So if you're moving their body around, there should be zero tensing or reaction. As we mentioned, create a legacy to do better if pain does occur, and apologize if warranted. I'm going to start to show you a few QR codes, which I know that aren't necessarily the easiest when you're doing a digital talk like this. So get your phone out and be ready to have some images taken of these QR codes. What you have here are a bunch of free CADA resources, from everything to what are the top 4 things that your pet owners are looking for to avoid a dyskinesia. Those good euthanasia, 14 essential components, aftercare resources, all kinds of things that we have for you. So just know that those are available, and you can also search those out on our website. Oh, call in the experts ahead of time. I forgot that one was in there. If you are interested in continuing the conversation, this is our CADA Facebook group. And there you've got the URL, so you could take a screenshot of that, or you've got the QR code. But we have close to 3,000 participants from around the world, where we talk anything you want related to euthanasia and a variety of species. And many of the discussions are around avoiding pain. You can join this at any time. This is for all veterinary professionals. This is for shelter personnel. Anyone who's performing euthanasia can participate in these conversations. If you are interested in becoming a CPEV like me, that's a certified peaceful euthanasia veterinarian, or a certified peaceful euthanasia professional for non-veterinarians that are in euthanasia spaces, then you can take CADA's 10-hour race-approved peaceful euthanasia certification course, 10 hours to get these credentials, and then you just continue with us 4 hours a year, very simple, to keep those credentials active. And we're going to teach you all of the very skilled ways beyond today, deeper techniques, deeper information to prevent that pain as much as possible, as well as all the soft skills that you can use in euthanasia too. And this is just a little coupon code for you in QR code form and URL. Also want to share some resources from our parent company, Lap of Love. A lot of things that they've been putting out for years and years. And you can access this at any time going to their website with those vet resources. And let's leave it on this slide to talk a bit on those questions and answer what you got. And I'm going to do my best. This type of talk usually generates a fair amount of questions, so I'll do my best to touch on those. And as always, thank you to Zomedica for bringing me in.